So do I press anything on here? It'll set to 0 when I hit it. So it counts up. Okay. Yep, it's going up. Five. I've changed my mind. Hi, everybody. We're going to reconvene in 1 minute. So please take your seats. And if you're out in the hallway, please come on in. Okay, hi everybody. My name is Justin Bond. I am an epidemiologist at the Sentinel Operations Center, and I'm going to talk about the self-controlled risk interval tool today. I just want to clarify that this is a presentation giving you some examples of how the self-controlled risk interval design can be used using the Sentinel system, but it's not necessarily a technical presentation that will teach you how to use the tools in all its specific technical parameters. So we're going to go over an example study and overview of the design. So just to orient you to how to access these tools, this is the Sentinel website, the sentinelinitiative.org. The highlighted link will take you to the documentation, which looks like this, and you can click the highlighted link here to access the specific documentation document. It's a long PDF that looks like this, and on page 12, you can find the description of the self-controlled risk interval design, and also directions for how to specify a self-controlled risk interval analysis using the tools that we're talking about today. So we hope that you will go online and read this documentation and download our tools to use it. So the agenda for my section of this talk is to describe briefly the ARIA workflow, which you've already heard quite a bit about, and then talk about the level 2 capabilities in ARIA. And then the meat of the discussion will be the case study, which relates to contrast MRI and MRA and the risk of seizure. We'll talk a lot about how to use the self-controlled risk interval design, defining a cohort, choosing the correct windows, and how to proceed with the analysis. And then we'll talk a bit about differentiating case-only designs so that those of you who are familiar with other case-only designs, such as the self-controlled case series approach, which is sort of a more general version of the self-controlled risk interval approach, will understand better what our tool does in comparison to the other things that are out there. So just briefly to review the ARIA workflow, ARIA is Sentinel's routine querying system. It stands for Active Risk Identification and Analysis, and it consists of modular SAS programs that identify populations of interest, characterize them, and perform comparative assessments of different products, procedures, etc. No new programmatic code needs to be written to use these, so that's the modular aspect of these programs. And there are 3 levels of analysis that these programs can do. Level 1 is descriptive or comparative analysis with no covariate adjustment. Level 2 is comparative with covariate adjustment. And level 3 is comparative with covariate adjustment and sequential monitoring. So today's talk is about level 2 specifically. There are 2 level 2 capabilities. You've just heard Jane's excellent presentation on the propensity score matching and stratification tool. This is a new user cohort design. There's explicit control of non-time varying confounders, pre-exposure confounders. And this is the observational analog of the randomized controlled trial, or RCT. It really asks, why does this happen to them? That is, why does some outcome event happen to one group of people more than another group of people? In contrast, the self-controlled risk interval tool, which I'm going to talk about, is a new user case-only design, so that only individuals who experience the outcome of interest will contribute to the analysis. It implicitly controls factors that don't vary over time within individuals, since it's a within-person comparison. And it's useful for studying the acute effects of intermittent exposures. So this kind of asks the question of, why does this happen now? Why did a patient experience an outcome event at this time relative to exposure in comparison to another time? So just to embed this difference in your mind, these 2 diagrams kind of differentiate the new user cohort design described by Jane, that's used by the PSM tool, or the PS analysis tool. In the new user cohort design, there are 2 exposure groups, here Group A and Group B, and they're followed from exposure initiation until the outcome of interest, denoted by the star here, or loss to follow-up. In comparison, the self-controlled risk interval involves the definition of a risk window relative to exposure when a exposure is hypothetically able to have an effect on the outcome, and a control window when it's not. And we merely compare the frequency of the outcome in the risk window to that in the control window to assess the effect of the exposure on the outcome. So a bit of motivation for this design. The self-controlled risk interval design was created to study vaccine safety, and it is a special case of the self-controlled case series method, which is a more general approach we'll talk about later. There are several relevant issues in vaccine safety that led to the development of the SCRI design. One is the lack of the appropriate comparator group. So in vaccine studies, occasionally you would want to compare vaccinees to non-vaccinees, but often those who don't get vaccinated are very different than those who do. And it may be difficult to identify a good comparator group for patients receiving some vaccine. Likewise, we may be interested in rare outcomes. arms of a vaccine. So that makes cohort methods somewhat difficult. Furthermore, pooling of multiple data sources may be required to achieve the desired sample size. Excuse me, I'm coming down with a little cold. So in order to, do this study design, we need a design that's self-controlled so that there's no between-person confounding, a design that's efficient, that does not require follow-up of large numbers of patients, and a design that's privacy-preserving so that we can pool multiple data sources. Excuse me, sorry about that. So we're going to talk a bit about the contrast MRI versus MRA and seizure risk case study. Just to clarify here, MRI stands for magnetic resonance imaging, and likewise we included magnetic resonance angiography. Excuse me. So gadolinium is a rare earth metal, and it is paramagnetic at room temperature, and it's used frequently in MRI contrast agents to enhance images. For this reason, it's often been referred to as picture juice by radiologists. Excuse me. And you can see in the image at the right what a MRI image without contrast looks like in comparison to one with contrast. So these contrast agents are injected prior to scan, and they will ideally enhance the image to the extent that we can identify things like what's seen at the right, which is a defect in the blood-brain barrier. So the concern that arose in this case is about seizure triggering. In particular, there is a biologically plausible scenario in which gadolinium deposition in the brain could trigger a seizure. There was some evidence from animal studies to support this hypothesis, and there was limited clinical evidence or anecdote. There was also a series of 183 FDA adverse event reporting system reports of seizure occurring within 1 hour of contrast MRI, and some of these were fatal. So this motivated FDA to really look into this further. And this is a screenshot of a recent study about gadolinium deposition after contrast-enhanced MRI imaging, just to demonstrate that this is an issue relevant to the community currently. So before we get into the tool itself, we have to talk again about assessing ARIA sufficiency. So this is the stoplight framework that you're now very familiar with. And it provides a simple metric to describe whether or not we can use the tools to assess a certain exposure or outcome. So, sorry about that. For exposure sufficiency, you can see here that there are several green pathways to get to an exposure that is workable for the self-controlled risk interval tool. In this case, we want to know, is ARIA sufficient to study contrast MRI or MRA? In this case, because contrast MRI is medically attended, it's an outpatient procedure, we can identify it in claims, and we can use it for the self-controlled risk interval tool. I'd also like to note that specific contrast agents are not identifiable in claims in a reliable way. So this makes actually identifying gadolinium itself, exposure to gadolinium, quite difficult. However, the majority of contrast agents that are actually used do contain gadolinium. So in this case, we're using contrast MRI and MRA in general as somewhat of a proxy for gadolinium receipt. So we can see here that contrast MRI is sufficient for the assessment with this tool. So for our cohort defining exposure in this case, we had 4 categories of interest. Contrast MRI or MRA during an ambulatory visit of any type, or specifically on the non-extremity region as well as the extremity region. There was also non-contrast MRI or MRA used as a negative control exposure. In this case, because non-contrast MRIs involve no exposure to gadolinium, we can use an analysis of non-contrast MRI to determine whether or not the MRI itself and not the gadolinium conveys an excess risk. All of these were defined by procedure codes during an ambulatory visit, and we ran the analysis separately for each category. So for the outcome sufficiency assessment in this case, there are a few additional considerations for the SCRI tool. One specific being the acute onset, which is necessary for an SCRI design. This tool is not particularly well suited to studying non-acute events that have a long induction period, things like that. Since the assessment is based on defining a window relative to exposure, we need to really be able to identify whether the exposure definitely preceded the event. And accurately dating the occurrence of that event is thus very important. So in this case, the seizure outcome, which we chose, is sufficient because it's acute onset, there are clear diagnostic criteria, and it's well coded. So we believe that we can be certain anybody having the codes that we identified actually had a seizure. So our outcome definition was defined using the International Classification of Diseases as epilepsy or convulsion in either of 2 settings, the emergency department setting or the inpatient stay setting. And you'll notice that this was done to sort of identify an escalation of care from people receiving the MRI during an ambulatory visit, so not in the hospital as an inpatient and not in the emergency department, and then having a seizure in the emergency department or inpatient setting to kind of identify specific patients who were not deemed to be at high risk from the beginning when they got their MRI, but their care was escalated because they had a seizure. The positive predictive value for confirmed seizure using the method that we chose to define seizure with these codes was between 79 and 99%, depending on the setting. So this is a relatively accurate outcome algorithm by pharmacoepidemiological standards. And in particular, I'd like to note that we define the outcome with a 183-day washout relative to itself, not exposure. And so because of the way the self-controlled risk interval design works, you need to define the outcome relative to itself so that people cannot contribute outcomes in multiple windows. And we'll talk about that a bit later. So I just want to also go over when to use this design. We've already talked about the outcome being acute, but we also need to use an exposure that's a fixed event. It has to be identifiable in claims, obviously, and it has to be accurately dated since we're aligning all the events on a timescale relative to exposure. The outcome must likewise be acute onset, as we talked about. It also has to be identifiable in claims, and it has to be accurately dated. And so I think what might be helpful for you to understand this is a few bad examples. So one bad example of an exposure would be a continuous use of a drug. Since this isn't a fixed event, the date on which somebody's a continuous user is at the very least ill-defined and often not well-defined at all. Likewise, over-the-counter products are not identifiable in claims and therefore wouldn't work very well. Furthermore, procedures or diagnoses occurring during a hospitalization are not often accurately identified in claims because they're often backdated to the date of admission. And so if we wanted to use a procedure occurring during an inpatient hospitalization as an exposure, we might not be certain that the date provided in the claim is actually the date of exposure. It could just be the date of admission. And in our common data model, all inpatient procedures and diagnoses are assigned to the admission date. So we know using our data that's not an acceptable method. Likewise, for the outcome, one bad example might be Parkinson's disease, which is a disease that has a very long induction period. Identifying and diagnosing the disease is difficult, and often we believe that the disease occurrence probably occurred long before the actual diagnosis. Cause-specific mortality is another bad example, because in claims data, often we may know about the death date of an individual, but we often do not know the specific cause of death, even if we have some claims on that date. And likewise, for the same reason as discussed before, procedures or diagnoses occurring during hospitalizations or inpatient stays are not accurately dated. So they would be bad for use with this design. So just to go over the design itself, there are broadly 4 steps for an SCRI design. First, we identify exposed individuals. Second, we define a biologically relevant risk and control window relative to that exposure. We restrict the analysis to those experiencing an event in either of those windows, and we compare outcome frequency in the risk window to the control window. In this diagram above, you'll see many more versions of this as we go forward. Just indicates generally the timeline here, and we will also talk about how to place these windows, how long they should be in relation to each other, etc. But generally, the important thing is to define biologically relevant windows that make sense given the medicine and science behind the exposure you've chosen and the outcome you've chosen. So just another aside about confounding with this design, because the comparison is between periods and not persons, that is, the comparison is between the risk window and the control window and one versus the other, each patient is serving as their own control, which means that measured and unmeasured confounders that don't vary over time are automatically adjusted for. And this is true of all case-only designs, but it's a very large advantage over other methods that require things like propensity score adjustment in order to adjust away the differences between groups. However, this design is susceptible to time-varying confounding. In particular, seasonality in the exposure and outcome, and both are required, can bias the results of the design. Likewise, relatively small changes in age among children can be meaningful because among children, small changes in age may actually meaningfully impact their risk of various outcomes. And especially if you're looking at very young children, you may need to measure age on the level of days or weeks in order to accurately assess the variation in outcome incidence. Likewise, common triggers of exposure and outcome can bias SCRI results. And an example that I've provided here is the PPSV vaccine, which is often given before a splenectomy. And so what we need to think about here is that if you are vaccinated, it's very likely that right after that vaccination, you've received a splenectomy. And if we went into the SCRI design with the intention of assessing the effect of PPSV vaccine on some other outcome, not knowing about its prophylactic use before splenectomy, we may end up seeing a higher occurrence of some event that's just related to splenectomy. And so it's really crucial here to just understand the clinical medicine that's going on around the time of exposure, and making sure that there aren't things that are being administered to patients immediately before or after that could influence the occurrence of the outcome. So you've seen this comparison before between the new user cohort design and the self-controlled risk interval design. And I just want to make clear again that in this case, for the new user cohort design, we're really comparing groups of people. So we're comparing the average incidence in group A versus group B, and we need to statistically adjust away the differences. In the self-controlled risk interval design, we're comparing the frequency of the outcome in the risk window to that in the control window, and all of these comparisons are within persons, and so we do not need to make those statistical adjustments, but we do need to worry about what's changing within that person between the risk window and the control window. So here, I would just like to hammer home the idea that SCRI is not subject to between person confounding, as long as those factors don't vary over time, but it is highly susceptible to bias arising from time-varying trends in medical practice and in outcome risk factors. So you really need to think very carefully about what's going on right around that exposure time. It's probably becoming monotonous now with me telling you all about this. So you may be wondering why we chose the self-controlled risk interval design to assess this question of MRI and seizures. And the reason we did so is that the outcome occurrence for seizure is very acute. The issue that arose in the medical community was really about the occurrence of seizures immediately after MRI, and so we knew we were dealing with an acute outcome. And likewise, the risk window was essentially predefined by the concerns that arose of the seizure occurring on the same day or within an hour. So this made SCRI an attractive option for studying this, which isn't to say this question couldn't be assessed with a cohort design, but it would be more difficult. There are issues with identifying the comparator group, likewise, if we were to go with the cohort method. So who would be the unexposed population to compare to individuals receiving contrast MRI? We could use an unexposed group, but then those people are probably less or more healthy than the people getting MRIs. We could even use the non-contrast MRI group, but people receive contrast MRIs for very different reasons than they receive non-contrast MRIs in many cases. And so that may be inadvisable. And so in our ARIA tools, likewise, it's not possible currently to compare to a non-scanned population, or in the more general sense, a unexposed population. We require an active comparator. And so the SCRI design turned out to be a very reasonable way to assess this question using ARIA. And so the basic idea was, if contrast MRI triggers seizures, we should see a higher incidence soon after the scan. So in terms of defining a cohort for SCRI, there are the traditional components that you're familiar with: the study period, the cohort defining exposure and its washout, the baseline period and its inclusion and exclusion criteria, and the outcome definition and its incidence criteria. And we've already talked about two of those. For SCRI, the only other components we need are really just the definition of when the risk window and the control window start and end. And so in our case study, the inclusion criteria involved including anyone who had a cohort defining MRI or MRA during the study period, who was 2 years or older at the time of the scan, and had continuous insurance enrollment for the 183 days or 6 months before their scan. We excluded people with same-day scans, as well as head MRI or head CT scans, and those with a history of several different conditions in the 183 days before their scan. So a history of MRI or MRA, seizures, epilepsy, anti-epileptic drug use, MI, stroke, syncope, brain tumor, etc. We're trying to really get the population down to the people whose risk of seizure is not due to other comorbid factors. So in terms of defining the input parameters in our modular programs, there are several things you have to choose. You start with, obviously, the exposure. What's the cohort defining event? Then you require a washout for that exposure, some incidence criteria that tells you that this is a new exposure. Likewise, any inclusion or exclusion criteria, you need to specify a look-back period during which you'll assess those. And you needed a continuous enrollment requirement that should be larger than whatever, or the same as whatever the look-back periods are for the exposure and the inclusion-exclusion. So we need to have the data on individuals so that we can be assured we can assess their variables in the claims. Likewise, we need to define a risk window relative to exposure and a control window relative to exposure. And we also need to define an outcome washout period. And I've talked about before the fact that we can't allow people to contribute outcome events to multiple risk windows. And so the next discussion is about minimum outcome washout periods. So essentially, we need to define a washout period that's large enough so that people can only contribute an event to one window. In this case, the top washout window, window A, is satisfactory, whereas the washout window below, washout B, is not, because as you can see, it's technically possible for somebody to contribute an outcome early on in the risk window and later in the control window. In terms of window placement, there's no rule that these windows need to be the same duration, the same, or need to be adjacent. So you can see in this slide that there can be windows that either are adjacent or non-adjacent, and there may be reasons why you don't want to have them be adjacent. You may be worried about kind of the risk bleeding over from one window into the other and want a gap, or you may want them to be next to each other to just maximize the amount of data you'll have, because the longer your windows are, the more people can contribute events, the larger your sample size. Likewise, you can technically have a control window that comes before your risk window. In this case, you have to ensure that the outcome doesn't affect the probability of subsequent exposure, because you wouldn't want a scenario in which you could have the outcome in the control window, which would really prevent or reduce the likelihood of you being exposed subsequently, and that would bias your analysis. So you have to make very strong assumptions about the outcome and its effect on future exposures if you want to do this. And it's not generally recommended, but it's technically feasible within the tool, and it's occasionally seen in practice. You could also have a pre-risk control window. There may be a scientific reason that you believe that the effect of an exposure on an outcome may have some delayed period before the exposure can change the outcome incidence, and you may want to use that period as your control window because you know that there's no possible way exposure can cause outcome for, say, the first 7 days. So that's another way you can align the windows. So in our study specifically, what we chose was obviously MRI and MRA were the exposure. They defined day 0. We used a 183-day washout for the exposure and a 183-day look-back period for the inclusion and the exclusion, and also for the continuous enrollment requirement. Our risk window is, in this case, not much of a window. It's just day 0. We were interested in same-day seizure because that's the issue that arose clinically. We could have done a larger window, but because of the specific question at hand about same-day seizure triggering, the risk window is just day 0. The control window was chosen to be days 1 to 42 to assess time at which an immediate triggered seizure was not a possibility, and the window was chosen to be long enough to get a reasonable amount of data, but not so long that we're no longer looking at things relevant to the exposure. And we chose a 183-day washout period for the outcome so that somebody can only contribute an event in one window, and we would be studying seizures that were relatively new. So every seizure that counted as an outcome in this study is the first within 183 days. So for each exposure level, and I've told you previously that there were 4 different types of MRI that we discussed, that we assessed, we output 2 cohorts in the ARIA SCRI tool. One is the exposure cohort, which we use to just characterize the exposed population. This includes all patients meeting the inclusion, exclusion, and exposure criteria, regardless of whether they had the outcome of interest. So they didn't have to have the outcome to be part of the exposure cohort. And what we produce for that is what you might think of as a table 1, a kind of tabulation of pre-exposure baseline characteristics age, sex, comorbid conditions, etc., which just kind of lets you assess the population receiving the exposure. The analytic cohort is what's actually used for the effect estimation, and that only includes patients from the exposure cohort who have an outcome in the risk or control window. So you have to be in the exposure cohort, have the outcome, and it has to occur in either window. So if it occurred between the windows or outside the window, you're not counted in the analytic cohort. And in this cohort, we assess the event counts and incidence rate ratio estimates, and we also provide a histogram of event times. And we'll go over the specific output from the tool right now. So for the exposure cohort, like I said, we characterize it with what might be considered to be a table 1. All exposed patients meeting the eligibility criteria for the study are included. And so in this case, we would actually have 4 different tables of this type because we have 4 different exposure groups. In this case, we're looking at the table for contrast MRI and MRA, regardless of extremity versus non-extremity status. So this is the overall group. And you can see that there were 1,708,779 unique patients contributing to this study, or contributing to the exposure cohort. You can also see that their mean age was 49.5 years at the time of scan, and that 60.3% of them were female. There are several other characteristics here that I won't go over now, but and in fact, you can define as many of these as you want. So our table was much bigger. It's been shrunk here for the purposes of presentation, but generally you would receive one of these for every exposure level you specify using the tool, and you can assess the population receiving the exposure in general. For the analytic cohort, data is provided on the number of events occurring in each window, as well as the number of index dates, and an estimate of the relative risk. And I'll go over in a second how the relative risk is calculated. But I just want to draw your attention to, first, I'm only going to cover the results of the extremity or non-extremity contrast MRI group, as well as the non-contrast MRI group for the same body parts. And I want to draw your attention to the fact that the number of patients in the exposure cohort is not the same as the number of index dates. And the reason for that is that in this case, we allowed people to enter the cohort multiple times as long as they satisfied all the washout, look back criteria. And so the number of index dates in this case is substantially larger than the number of patients, which means that everybody who contributed multiple exposures, multiple scans, actually had a contrast MRI or MRA, satisfied all those criteria, was followed for the outcome, and then later on in their life, again, met the criteria for all of the study washouts and lookbacks and contributed again. And so that's a parameter that you can choose using the tool. You may decide that you only want to allow people to contribute one exposure to the analysis. In this case, we allowed for multiple, and that's just up to you, and excuse me, may just reflect your desire for more or less sample size. So in this case, there were 1,991,158 unique index dates in the exposure cohort. 317 valid events occurred in the analysis cohort. Of those, 25 were in the risk window and 292 were in the control window. And I just also want to point out here that this is quite a rare event, same-day seizure. Out of all of those index dates, 317 had seizures on them, which means that the actual incidence of the outcome was only 0.015%. So this is quite a rare event. Would be somewhat difficult to study this with a cohort study. You would have very low power when you went to estimate the relative risk. So like I said, of these 317 valid events, 25 occurred in the risk window and 292 occurred in the control window. And the relative risk estimate was 3.49, and the way that's derived is just by comparing the frequency of the event in the risk window to the control window. And you'll note that since the risk window is only 1 day in duration, whereas the control window is 42 days in duration, when we actually account for this difference, we can see that the same-day seizure is occurring at a rate of 3.5 times greater in the risk window than in the control window. And I'd also like to point out, if we look at the non-contrast MRI results at the bottom of the slide, that the final relative risk estimate is 3.35, which is actually relatively close to what we see for contrast MRI. And recall that non-contrast MRI recipients are not exposed to any amount of gadolinium. And so what this is saying effectively is that having a contrast MRI, being exposed to gadolinium, does elevate your risk of same-day seizure, but not much more than does non-contrast MRI. So this is some amount of argument for the gadolinium not being the real causal factor in the occurrence of seizure on the same day as MRI. So the SCRI tool likewise outputs a distribution of events. So this is just a histogram showing the number of events occurring on every day relative to exposure. Here, our risk window is just the first bar, just day 0, and the control window encompasses day 1 through day 42. If you defined a window that was discontinuous, that had a gap between it, you would only receive a histogram that had the days on which the windows were actually valid. That is, your histogram would only include the risk and control window, and you wouldn't see any events occurring on those other days. So in this case, and I don't know if you can see this because it's white text, but you saw it in the table before, we have 25 events occurring on day 0 in the risk window and 292 events occurring during the control window. And so we can see that the relative risk estimate is 3.5, and thus contrast MRI or MRA is associated with a 3.5-fold increase in the rate of seizure. These are the results for non-contrast MRI. And as you can see, the number of events is much higher day to day because there are more people receiving non-contrast MRI than contrast MRI. But when we do the math, the results come out very similar. We get a relative risk estimate of 3.4, which means that non-contrast MRI is associated with the 3.4-fold increased rate of seizure. So we can actually do an indirect comparison between non-contrast MRI and contrast MRI and come up with a relative risk of about 1.04 comparing contrast to non-contrast, which is to say that contrast MRI conveys a only very slightly increased risk of seizure compared to non-contrast MRI. So to summarize our case study, we had a very rare outcome which made SCRI advantageous, in addition to the other things like the fact that we knew this was an acute onset outcome. We saw a rate of seizure that was 3.5 times higher on the day of contrast MRI than in the following 42 days, but this effect was nearly the same for non-contrast MRI. And overall, this suggests that gadolinium-based contrast agents are not the primary driver of increased seizure rates on the same day as scans. There could be many other reasons for that, and that the purpose of this talk is not to necessarily describe those, but I think this is very illustrative for how you can use multiple exposure categories in your use of the SCRI tool in order to do a sort of sensitivity analysis to get at whether your real exposure of interest is causally associated with the outcome. So I want to talk a little bit about differentiating the other case-only designs from the SCRI, just to avoid any confusion. And so we'll talk about two other designs. One is the case crossover design. Those of you who are pharmacoepidemiologists might be familiar with this design. And essentially it has 4 steps. In the first step, you identify all individuals experiencing the outcome during the study period. In the second step, you define an effect period, which is relative to the outcome, not the exposure. And so you define an effect period preceding the outcome. You define a control period also preceding the outcome, but during a different time. And you compare the exposure status in the effect period to that in the control period. And basically, if you estimate an odds ratio comparing the odds of exposure in the effect period to that in the control period, that can be proved to be an estimate of the incidence rate ratio comparing the rate of the outcome for those who are exposed to those who are unexposed. Now, there are several issues with this design, including its extreme susceptibility to time trends and exposure, which is often a very large problem in pharmacoepidemiology, since uptake of drugs is often increasing, and over time, the outcome occurrence is changing. And so this design is more susceptible to that. And you should also note that this is a case-only design, but not a new user case-only design. You can get into the case crossover analysis without being exposed. So everybody with an event contributes, not everybody with an event and an exposure. Likewise, the self-controlled case series design is a more general version of the SCRI design. In this case, you define one or more risk windows relative to exposure. In this case, there's 3 risk windows in the example. You assign all the other observed person time to a control window, and then you compare the outcome incidence in the risk windows to that in the control window. And so this is essentially the same as our SCRI design, but allowing for multiple risk windows. And there may be reasons why you want to do that. Perhaps you think that the risk is elevated immediately following exposure and even more elevated after a certain period of time elapses, after which it goes down to some other level that's still not back to baseline. And so this is a much more general strategy that allows you to assess multiple windows, but it does leave for more decision in the window placement and window definition, which can be difficult to make those scientific judgments. And I just wanted to point out that the self-controlled risk interval design is really just a special case of the self-controlled case series design in which we only define one risk window and we define one control window where it's essentially continuous in comparison to this, in which the control window is all the other person time, essentially. So in closing, I'd just like to point out that the SCRI design is a very simple analytic method. It compares periods, not persons, and identifies windows of elevated risk associated with common medical interventions. So one potentially important application of this tool is that if there are common medical interventions occurring in populations that you deal with a lot, this can be a tool for kind of screening windows of elevated risk after those procedures. Likewise, you should be wary that these results are very sensitive to the window choices. This can be mitigated to an extent with sensitivity analysis. You could use our tool, for example, specifying multiple risk and control windows in different scenarios in order to do a sensitivity analysis to determine if I make the risk window smaller and smaller and smaller, keeping the control window the same, does that change the results, etc. So the window choice may really impact your estimates, but you can use sensitivity analysis to mitigate that. And finally, I'd just like to point out that this can be very rapidly implemented using the ARIA framework, and I know that's why you're here. But this is a study design that's simple and kind of has a much more rapid implementation. So with that, I'm happy to take any questions you have about the design or about the study in general. And thank you very much.
Two questions. One, you may have answered that and I didn't get it. You could have done a cohort study comparing, with and without contrast material, right?
Yes.
Okay. Because then the 3.5 and the 3.4 would be directly compared, and would have probably washed out.
Correct. As I think I did mention this earlier, is that you could sort of imagine a cohort design in which the comparison is between non-contrast and contrast, but it's possible. I think the reason I mentioned was that there was potential for residual confounding due to some unmeasured factors relating to why you're not getting contrast in your MRI. But it's certainly feasible, and I think it was actually something that was thought about for this case study, and a feasibility assessment, I think, was done to determine if we could do it. So.
Oh, but we are not here to debate the study anyway. It was an example. So the other question is, you're saying that there are time-varying confounders. Is there something like a report that you produce for covariates that do change over time in these populations? I mean, age, for example, should show up each time, even though it only changes proportionally and slowly.
Yeah, so we do not have a default report for covariates changing over time in this study. It's assumed that you've made the kind of scientific conclusion.
Done your homework.
Yeah, that you've done your homework. But it's a good question that you bring up, and I think it's possible that other modular programs could be used to assess that. And so often we advise people requesting analyses from us to start with a, say, level 1 modular program analysis to determine whether or not this stage is feasible.
So I have a question. So when you go back to some of your earliest slides comparing the two different analytical constructs, you talk about why does this happen now, and what was the other one? Why does this happen to them? So it seems to me, and maybe I'm just splitting hairs, you're not really telling us why it happens to them. You're telling us whether it happens to them, and whether it happens to them in relation to the event. Right?
Yes, I think that's a more accurate description. Okay. So the question was about the difference between the cohort approach and the SCRI approach, and particularly whether it can more accurately be said that the cohort approach describes whether an event happens more often to one group than the other, whereas the self-controlled interval design describes whether the event occurs more frequently in the risk window to the control window. And I think that is a much better description, so thank you. I guess our phrasing was insufficient.
You started to talk about this design mentioning that it's used in vaccine studies. And so I was wondering if you had an example that you could talk about, because in particular, when you define that control window, and you mentioned that the control window before the exposure is sort of not what you would recommend, I've been having a hard time trying to see how that would apply for vaccine studies where the exposure is vaccination. To me, it would seem more intuitive that you would use a pre-exposure period as your control window rather than any kind of period after exposure. And so I was wondering if you had any kind of experience with that you could describe for vaccines.
So I don't have a specific vaccine example, but I can tell you that the self-controlled case series method that I described at the end, which is more frequently used for vaccine studies, that incorporates the pre-exposure control and the post-exposure control time. And it does so mostly for the reason of utilizing the maximum amount of person time possible. But I think you bring up a good point, which is that for a vaccine, nominally, its effect has taken place somewhat permanently after exposure. But for some outcomes, that may not be true. So it's possible that you're studying the effect of the vaccine because you think that the whatever keeps it thermostable or something like that could potentially trigger an event within the first 3 days, but not after. And so I think it's outcome specific. But it's not to say that you should never use a pre-exposure control window. You just need to be assured that if you use a pre-exposure control window, having the event wouldn't impede you from subsequently being exposed. And so for a vaccine, as long as the event isn't something like death or a major hospitalizing condition, you might be satisfied that if somebody has an event in my control window, they're just as likely to go and get the vaccine afterwards as they would be if they were otherwise healthy. Yeah, Judy,
Sorry,
I think would
wanted
like to add to that.
Yeah, because we've actually done work looking at that, and you can do this in the tool too. That's the part. You can define one scenario with a control window that comes pre-exposure, and then can define one with post-exposure and compare the incidence rates in those periods. And so particularly with known adverse events, so MMR vaccine is associated with both seizures and ITP. And if you look at those and you then take that into MMRV, so the quadrivalent vaccine that came out after MMR, there was concern for when you monitor MMRV, if MMR is associated with seizures, is MMRV in fact associated with seizures? And so there was a lot of study that was done to look at seizure risk in the pre-control and the post-control, and I can tell you just from looking at it that folks who have children that experience a seizure are unlikely to have the same probability of being vaccinated in the time immediately before. I mean, you're just going to get the healthy vaccinee bias there because you're a parent, you see your kid have a seizure, you know, are you going to take them in for the MMRV vaccine 2 days later? It's just not the same rate. And you can look at it numerically. And so the tool allows you to do both. So you can always do it as a test. Yeah.
Okay, so I've just received word that we received a question online. So I'm going to try to answer that. And the online attendee asks, if seizure happens very quickly after MRI or MRA, can you actually determine whether the seizure happened before or after the scan, since the dates are the same in the claims? And this is a really good question and something that we certainly thought a lot about. And from a technical standpoint, the answer is no. The dates are the same in the claims, and so we can't be assured that the seizure actually didn't happen in the morning and they were scanned later in the day. And this is part of the motivation for our sort of escalation of care method, where we define the exposure occurring in the ambulatory visit setting and the outcome occurring in the inpatient or emergency setting, to kind of sort of proxy the idea that we want the scan to be the thing that they came in for and the seizure to be a secondary event happening happening as sort of an escalation of care. However, this is an issue with claims data in general, is that on the same day, you can never differentiate which came first. So it's a very good question and something that should be thought about in any case when you want to define the risk period or the risk window or the control window to include the index date. So the question was just, how did we decide that the window was only 1 day? And I think I mentioned earlier that this was done just because of the clinical anecdote that came up about seizures occurring on the same day. And so we could have used a longer window. And you could actually see if we look at this histogram, you can kind of visually assess what would happen if you instead extended the risk window to include day 1 to 0 to 1, and then the control window from days 2 to 42. You could sort of do the math in your head and figure out that it would dilute your effect somewhat. But this window was chosen specifically because of the clinical anecdote, not because of any other reason. Okay, so thank you very much, and I think now we have a break for lunch.